Good morning to one and all present here. As we all know, laparoscopy in the world of colorectal surgery has almost become the standard of care since the last decade. However, ongoing debates are there as in which visualization method is superior to one another, whether is it 3D visualization or 2D, in terms of better patient and clinical outcomes. Previously conducted studies suggested that 3D visualization offered better depth perception and better task efficiency. However, real-life, high-quality evidence was limited in colorectal procedures as such. So with this trial, we tried to figure out whether there was any impact or benefit of 3D over 2D in primarily focusing on patient and surgical outcomes. So this is an ongoing pilot study being conducted at PGI Chandigarh. 50 patients who underwent elective colorectal surgeries have been enrolled so far, and they were randomized into both the groups, 2D and 3D. We assessed both the intraoperative and postoperative parameters and number of lymph nodes that were procured in the specimen. In postoperative parameters, we assessed if there were any complications in the postoperative period, any morbidity, the length of the hospital stay, and time to past first flitters. Coming to the 3D group, however, it was not statistically significant. In table 2, similarly, no statistically significant difference was found in terms of intraoperative timings of blood loss. Coming to table 3, we assessed the postoperative complications using Clavier classification, and we noticed that the severity of complication was higher in the 2D group as compared to the 3D group. In table 4, we had various parameters which were subjective parameters, and we gave the surgeon a feedback form wherein the surgeon gave ratings from 1 to 10 after performing the procedure in all these parameters. And we can see that apart from ghosting, all the parameters we assessed the intraoperative errors, the stay and time to pass the first flitters. However, no statistically significant difference was found in both the groups. So to conclude, an interim analysis of the study revealed no significant difference in the clinical outcomes, be it intraoperative or postoperative. However, with ergonomic and visual benefits of 3D laparoscopy, surgical performances can be enhanced, and it can potentially improve the patient outcomes and the surgical outcomes with larger cohorts and longer follow-ups. Thank you.
Thank you, Yash. Can I ask you, was your sample size adequate to show the difference in complications? Do you think the sample size was adequate?
Sir, actually this is an ongoing study. So we are recruiting patients till December. We are recruiting, and as of now, it is not it's not right to say regarding the sample size. So with higher sample size, we can conclude better.
To the floor.
Yes, sir. Yeah. What was your primary outcome measure that you were looking at?
So primary outcome was the intraoperative parameters, wherein we assessed the number of lymph nodes that were extracted in the specimen and the postoperative stays of the patient in terms of
one primary outcome. So you can calculate your sample size based on a single primary outcome,
yes,
unless you want a composite outcome.
Yes.
So my question to you is, what was your primary outcome based on which you calculated your sample size?
Yes, sir. We calculated the sample size based on the lymph node yield. It was like in previous studies that were conducted. We assessed that the 3D group should improve the lymph node yield by 10 to 20%. So with alpha error of 5% and beta error of 10%. So
my second question to you is, you've got two modalities, 2D and 3D.
Yes.
So both modalities, the people who are operating need to have a certain proficiency or a certain amount of experience using them before you can start comparing these. So what was the kind of experience that the people who were using the had?
Yes, sir. All the surgeons who were operating, they were equally proficient with the 3D and 2D visualization, and they had no personal preference as in which method to use for the patient. It was
So how do you know that they had a personal preference? So you ask them, you have no personal preference, and therefore you are allowed to operate and a person who did have a personal preference was not part of the trial? Was that the way it was done?
No, sir. They were equally doing 3D and 2D procedures, sir.
So Yash, I have a question to you. Taking forward Dr. Piyush Sahni's question, is what was the level of seniority of the operating surgeons? Were they senior residents, assistant professors, or all professors and associate professors?
Sir, all were consultants, assistant professor and associate professor.
So same set of surgeons operated all the patients
Yes.
with randomization.
Yes, sir.
So logically, the only advantage would be your suturing and your precision. Lymph node yield should not matter between between the two arms. Besides, the European Society of Endoscopic Surgeons in their 2018 consensus meeting, they said that the moderate with regards to this 3D is at present very moderate evidence, weak evidence rather than a strong evidence. And the only advantage they say is for the suturing and not for the lymph node yield at all. Okay. So, thank you very much, Yash. We move on to the next speaker.
So we